We have Pranav Periyalwar.
Close enough.
That's okay. And you are gastroenterology.
I'm a GI gastroenterologist
Okay.
at the University Hospitals, Geneva and Conneaut.
Okay, Digestive Health Institute. Okay, and so tell me, what exactly is that?
So a gastroenterologist is a person who takes care of the GI tract, basically from the mouth until the rectum. So it includes the esophagus, the stomach, the small intestine, and the large intestine. So I deal with diseases and infections of all of those, including the liver and pancreas.
That's a lot.
It is a lot. It's a lot, yeah.
So when you were a kid, did you always want to do this?
I didn't know. So something that came to me more in medical school. It's a part of medicine where you have a kind of encompassing multiple roles and lots of procedures, as well as seeing patients in clinic and in the hospital. So it kind of gave me a lot of a breadth of things which I could take care of.
So you were in medical school and you wanted to see where you wanted to kind of specialize in?
Right.
And found a need here or an interest? Or?
Yes, absolutely. I think it's a big need. Everyone at some point in their life needs a gastroenterologist. So I think it's important that there's enough of them to serve the people.
Is this also a position that's kind of gone wanting around here? Or?
Absolutely. It's been 10 years since there's been a UH gastroenterologist at University Hospitals in Conneaut. So right now, there's a big need for that, and they saw that there was a need, and that's why they brought me in.
So what did they do before this? Send you off to Cleveland?
Right.
Or?
You'd either have to go to Cleveland or to Geauga. For the most part, there are some general surgeons which are taking care of this, but that's really not their role to be doing this. So right now, I think there'll be a glut of patients which are in need.
Mm-hmm. Yeah, I bet. Okay, so tell me then specifically, what is it that you do? You see a new patient.
Right. Well, I see patients in clinic. I also see referrals from the hospital. And I also do procedures in the operating room. So I kind of do many different things. If I have a referral from an outside physician, what I typically do is I'll see them first and get to know them and what their problems are, and we'll kind of assess to what we need to do. If it means doing an upper endoscopy or a colonoscopy, or further lab testing or imaging, we'll come up with a plan together, and we'll go through that plan and tackle it one by one.
So the patient becomes part of all of this?
Absolutely. I consider patients to be a part of the team, and I hope that we have a good patient experience.
So give me some examples of things people come in with.
I deal with, I'll start from the top. I mean, a lot of reflux. Acid reflux is a big problem. And a lot of the people who have reflux don't see a doctor at all. They wait for years before they see a doctor. Many people don't know is that acid reflux leads to a condition called Barrett's esophagus.
Wow.
And that is precancerous, so you can get esophageal cancer.
Is that like burning?
It's burning acid coming up. I do a lot of irritable bowel. So people which have constipation or diarrhea, having difficulty passing their bowel movements. Anyone who has any liver issues, whether it's
the bowel thing. I know some people. Whatever. It seems like it's an ongoing problem, and that it doesn't get solved for them. Is that something that
it is? It can be a lifelong struggle, but there are medications and there's ways, techniques which I have at my disposal, which many other doctors may not know about, and ways which you can make their life better. So
somebody that had this problem 5 years ago, and the doctor says you just got to live with it. Maybe there's some new procedures or something.
We have newer therapies which are coming out, and newer medications which are coming out which help with that. I also deal with the pancreas, the liver, and I think one of the biggest and most important things is I look at the colon, which is the large intestine. Everybody at some point in their life needs a colonoscopy, and ideally it's at age 50. If you haven't had one and you're over age 50, then you're overdue for getting it done. And it's especially important in patients who have had family history of colon cancer.
Because I'm over 50, I've never had one.
Oh, really? So yeah, it's the only proven way to detect colon cancer and treat colon cancer. If you get that done, you can rest assured and sleep well at night that you will not have colon cancer. The interval for colonoscopies can be anywhere from 6 months to a year to 3 years to 5 years, or as many as 10 years. So if you get it done and you have no polyps at all and no family history, you may not need it again for 10 years.
Okay, so what's the difference between the results at 10 years and 6 months?
6 months.
Because
Well,
6 months sounds awful soon.
6 months is soon. 6 months is generally for a case which we had a large polyp and we couldn't take it all out basically.
Okay.
And we want to make sure it doesn't recur or there's no evidence of cancer at the site. For the most part, it'll be anywhere from 3 to 5 to 10 years.
Mm-hmm. I had a friend that had several of them, and he was admonishing me before about not having them, and he did have them, and it has nothing to do with this, but he has since died.
Oh,
but he would talk about, well, my first one, I had to drink this stuff, and it was terrible, it was 90 gallons, and the second time it wasn't quite so much stuff, and it was this color, but it still tasted terrible, and then it was even less stuff the next time. I mean, he'd memorize all the junk he had to take for this thing. So tell us about the pre-op.
Right. So the prep is actually what many patients tell me is actually the worst part of the procedure.
Because they go to sleep, right, during the thing?
Right. Yeah. We'll use an anesthesiologist who works with me to get you to sleep, fully asleep. So the worst part is actually the prep, and I try to make that a little easier. I have a few preps which I use, which are lower volume, less quantity of liquid, and just as effective. So, I generally speaking, I don't like to use the large volume prep unless it's absolutely necessary, or if insurance for whatever reason doesn't cover the other.
Really? The insurance will say you
sometimes. Sometimes I had that experience just last week where I tried to give a lower volume prep to a patient and the insurance didn't cover it. They were charging them. So
is it more expensive?
No, it's really not. I mean, most of them are over-the-counter preparations, which I just use different methods for using these over-the-counter preparations. So it's primarily, covered fully. So
this is probably somebody in an insurance office with absolutely no medical background whatsoever that's telling you this?
Yes.
Have you ever put your fist through the wall after one of those
it's very, very frustrating. It's very frustrating because you're trying to convince people what patients need, and what's best for patients, and that's my goal, just to make sure we do what's best for the patients.
So when people, I'm sure that they all dread it. So what do they say afterward?
They say that really it wasn't as bad as I thought. That really I didn't feel anything, and sometimes they don't even remember that I did the procedure just then. They said, "Oh, is it done? Or are you going to do it now? Or are you going to start?" I said, "We're all done. Everything's done.
Everything's good."
Yeah. So really, I think it's the day before which is the most difficult. And if you can get through that and come in, then we'll take good care of you, and you'll be feeling great.
And so you're at UH Conneaut. Are you also at Geneva?
I am. I'm at Conneaut every Thursday, and in Geneva Monday, Tuesday, and Wednesday.
Okay.
So whatever is convenient for people, I'm happy to see them at either site, and based on where they live or their schedule.
Okay. So if Tuesday's better and they live in Conneaut, then you just go to Geneva.
They can go to Geneva. Yeah.
The colonoscopy. Can you tell me some lifestyle things that may contribute to polyps?
Right. There's many different factors. There's actually a lot of research going on right now for what causes colon polyps. It can be a family history, genetics. It can be dietary intake. It can be a lack of exercise. Certain obesity may play a role. And more importantly, what's come in vogue is the gut microbiome, which is the bacteria which actually live in the gut. So some patients have certain makeup of bacteria, and that may prevent them from getting polyps, whereas others have a different makeup, and that may predispose them to getting it.
How about meat?
Meat? Well, there's no proven role, but there is some evidence that red meat can predispose to colon polyps.
Somebody says to me sometime that meat sits in your body for a week versus a radish that will be out the next day or something.
Well, I mean, generally they both will kind of go through at the same pace. I think that it's more just what the enzymes and things like that, how they interact with the food that causes polyps.
It's interesting you said exercise too. Exercise seems to be the answer to everything. Every
Right.
doctor I have on here says exercise is a factor in everything. It
Yes.
seems like.
Yes, I mean, there is some role that they say obesity has played in developing colon polyps and cancers, as we know. It also, predisposes patients to diabetes and heart problems and things like
Right.
that, which make you overall less healthy.
Right.
So,
What percentage of chances are there that the polyps are going to be cancerous?
it's generally it varies greatly. I will say that there should be out of every 4 colonoscopies I do, one person will have polyps, a significant amount of polyps. So there's a
Really?
25% chance. There's a 25% chance at the minimum that patients or people who are walking around right now have a polyp.
Is there any signs or any symptoms?
Really, they can. I mean, the key things to look out for are if you have any rectal bleeding, blood through the rectum. That's a key reason to get a colonoscopy at any age,
Right.
even at age 40, for instance. If you have a change in your bowel pattern where you're having more diarrhea or more constipation or thinner stools or bulkier stools, things like that. Those are all warning signs. Any weight loss, unintentional weight loss. I know patients know how hard it is to lose weight.
Then all of a sudden they lose weight.
Yeah,
and
if you
it's
lose
scary.
weight, sometimes people are really happy, and I say, well, you lost 20 pounds in 2 months. I think this is something else that's going on. We have to figure out what the reason for this is. So.
Could there be no symptoms and they have polyps?
Yes, you can. Yeah, that's possible. That's why we recommend everyone at the age of 50 to get a screening colonoscopy done. And earlier, age 40, if you have any family history.
Male or female?
Male or female.
Is it one sex over the other one? Have a?
No, it's pretty equal. I think men have a tendency to have more polyps, but that may just be, we don't know the reason for that. It could just be dietary or
Or they're eating more like salami sandwiches
Right.
watching a football game or something
possibly.
like that.
Yeah.
Okay, so it's not just colonoscopies that you perform.
Well,
So-
no, I do upper endoscopy, which is an important test to look for patients with reflux, as I alluded to before. Anyone who had reflux or any problems with bloating, any difficulty with eating food, and you're not feeling full really quickly after eating, again, weight loss, all of those reasons I would do an upper endoscopy. And that's a camera test where we look from the mouth into the food pipe, which is the esophagus, the stomach, and the small intestine. And we see, I could find anything from, as I said, Barrett's esophagus to ulcers, sometimes, other things which we don't expect to find. So it's very important to, if you have any of those symptoms, to go in and see your primary doctor and get them to refer to see me. I also have, we're starting an open access referral campaign at Conneaut and Geneva. So their patients' primary doctors can actually order a certain test, and I can review their file, and they can come and get the test done without seeing me in the clinic, if that's easier for them.
Oh, okay.
So whichever works. I'm happy to meet people first before the procedure, or if they, their time is valuable and they'd rather not meet with me and see me the day of the procedure, I'm happy to do that too.
You go in and say, hi, how you doing?
Absolutely.
And-
Yeah, I would check in and, go through their symptoms and talk about who referred them and all of that. So try not to make things too rushed and make sure everyone has time.
Well, my experience is, mine kind of limited medically, but then like when my parents were alive, I would go to, is that you get the feeling sometimes with medical people is this is what they do every day, all day, and it's such a routine for them. They know what's going on. And sometimes they don't always are able to convey that to the patient so much because to the patient it's all new.
Right, absolutely. And I think that's why it's important doctors speak at and talk to patients, and then after they finish talking, they say, did we, any questions or anything else I can explain better? I think the biggest problem is doctors use a lot of medical jargon.
Yeah,
And-
because they know
Right.
us. Okay, all right, that was nice.
Right.
No, English, please.
Yeah, exactly. So, I try to speak at the level that people will understand, and I hope that all my patients have a good understanding and better understanding of their diseases and the symptoms that they're having after they come and meet with me.
Okay. You're also an assistant professor of medicine at Case Western.
I am, yes.
So on that Friday that you're not in Geneva or Conneaut,
Yeah.
are you teaching classes?
I sometimes will be working with fellows and residents and be doing research, various different things. but I'll be at the main campus at Case on those Fridays for the most part.
I spent a day taking classes at Case once. So my son was a student and they had a Parents' Day thing.
Oh,
So
really?
it's all his classes for one.
Wonderful.
He's an engineer, he's not a doctor.
Oh, okay.
But they have a pretty good engineer class.
Yeah, I've heard good things about that. Both my parents are engineers, so
Oh, really?
I know a little bit about that.
Well, how long have you been in medicine?
Well, I did my residency and fellowship in Cleveland.
Okay.
So I've been in the Cleveland area for 6 years.
Do you live in Cleveland?
I live on the east side in Beechwood.
Okay.
So I commute in to Geneva and Conneaut. The reason I do that is my wife is an internist and she works out there, and we have 2 young children. So,
Right. So now I have a non-medical
Mm-hmm.
question for you. If something happens with my iPad or iPhone or something,
Mm-hmm.
can I give it to you and you can take it to the Apple store in Beechwood?
Sure, why not? I'm not far from it.
Yeah, it's just an hour drive. So.
Oh, right, yeah. God, the Apple products, you never know what's going to happen with them.
Yeah, but I don't want to get into that. But when I did have a problem, they fixed it real quick. It didn't cost me anything, so I
that's
can't
good
say
to
too
hear.
bad. So that's so how long ago did you get your? Did you mention how long ago?
I've been in the medical field for 10 years. I
Okay,
went to medical
yeah.
school and I did residency and fellowship in Cleveland. So I passed 3 years. I trained as a gastroenterologist and I did a fellowship in that, learning all the procedures and techniques.
And so you teach it. So as
Yeah.
you said, you have to go back to school, but heck, you're the one who would go back to teaching it.
Right. Yeah. No, I mean, I think, that as you progress through medicine, things you pick up more and more things. And once you finish your fellowship, you're ready to go out there and teach fellows or teach residents and continue to further medical knowledge, which is our
So
goal.
that everything, whatever you're in, everything's always changing.
It
I mean,
is.
we just had the school superintendent from Buckeye, and he's been in there since the 70s, and education is so much different than it was
is, absolutely.
40 years ago or whatever.
Absolutely. You have to keep up with it, and that's important. Doctors are always on top of the latest things, whether it's medical breakthroughs or technology. Everything's important.
Do you have people that, I know you see these commercials on television saying, tell your doctor that you want this or that. Do you get that kind of stuff?
I do, yeah.
And
Sometimes
do you subscribe, or is it most of the time that they're wrong?
Well, sometimes they're wrong. Sometimes there's something to it, and I really try to find out the reason why the patient's asking for it. That's the more important thing. And if we get to that, then I can figure out what I would recommend.
Right.
Rather than the drug companies.
Absolutely, yeah.
So I think that's kind of important. So if you spend the time and talk with the patient, say, well, why are you asking for this medicine? Oh, well, because I have really bad heartburn.
Okay, which is something like I wanted to mention.
Right.
Was because that's something that I never had, and in the last couple of years,
Okay.
I get heartburn, and that is part of the reflux.
Right. So, I mean, generally speaking, if you have new onset heartburn over the age of 40 or 45, we do recommend endoscopy per our guidelines, an upper endoscopy per the gastrointestinal guidelines.
So do they stick something down your
Yeah,
throat? You do that?
you're sedated and you're comfortable and you're very you won't remember it when we do the procedure. We use anesthesia. But we do recommend making sure there's no other complications or any other reason for having this new onset of symptoms. It's particularly worrisome when someone is over the age of 40 or 45 and they suddenly start getting this. Most of the time we won't find anything, and which is good.
Right.
But there is, on occasion, you can find certain cancers, esophageal cancers, gastric cancers, or really bad ulcers, or different things which we could have taken care of if we had known about it earlier. So
if it isn't anything, how do you treat it?
Well, if it's absolutely nothing, then we treat it with what we call a PPI medication, a proton pump inhibitor. And what they do is they suppress the acid level and should reduce your symptoms.
Okay.
Overall.
Okay, let's. So you're talking though about. Oh, also I wanted to mention you said something, put something down your throat.
Right.
I've been to an allergist because I got junk in my throat all the time, and the allergist never really solved that. But and he always would put something down through your nose or something, and there was no anesthetic or anything. It wasn't particularly uncomfortable. Is it something? Did it feel something like that? Or?
It could be similar to that. We always do anesthesia when we do these procedures, so they're very much in a comfortable situation. It's a long thin tube with a camera, and we take it from the mouth into the food pipe, which is the esophagus, and then go into the stomach and the small intestine. It's a very quick test. It's about 5 minutes long, and it's painless. And
5 minutes.
Yeah.
Oh.
Yeah. So it's really 5 minutes of your life to make sure there's nothing there.
Right.
You don't have to worry about that again. And then we can just use medications to treat it as needed.
I mean, how many people they'll go through stuff in their lives because they just dread the idea of going to a doctor or a dentist or whatever.
Right.
And it just doesn't. Afterwards, it's like.
Right.
I put this off for 8 years because.
Right. I encourage everyone out there to come in, at the very least, come in and speak with me in my office if you're scared or you're worried about certain things that which I've talked about. We can talk about it more. Maybe you don't need those tests. Maybe you do, and we can discuss what your fears are about it, and hopefully I can help to alleviate those and prevent certain long-term complications.
Right. What other procedures? You said that there's a number of procedures that you do. Is
right. Well, I do a lot of other non-invasive procedures, like we're looking at certain ultrasounds, MRI images, CAT scans, things like that. Also, there's other tests which we do for looking at patients which have acid reflux and heartburn, which look at the actual quantity of acid which go down there. There are many different methods and modalities which we do for that.
Okay. So do you have all of the machinery at both places? I don't know if it's called machinery, but medical devices.
Right. Yeah, we're pretty well equipped at both sites. I think that if you need to be seen at Conneaut or Geneva, and the other thing is we have the ability to take equipment from one side to the other. So most of Geneva is very well stocked. So if there's anything which I'm missing at Conneaut, I can always bring that. So you
have a station wagon and you haul stuff along with you, or?
No, I get it. There's a courier who'll bring it because I don't want to be responsible for. They're very expensive. Some of these.
I bet.
Each endoscope I think costs about $40,000. So it's really.
So it's not like we'll just take $20 out of your pay every week.
Exactly.
So there must have been a really big need for this to stock both two hospitals.
Right. I think it's a significant need right now. As I said, it's been 10 years since there's been a gastroenterologist in Conneaut. And that's a long length of time that people have been managing without it. So it's going to take some time for people to realize why they need to see me, and it'll take some time for physicians to realize that they can refer to me to see patients. But I think that the more that I get out there and meet with people, the more comfortable they'll be in coming on in.
How do they communicate that with other physicians? That we got this guy here now.
Well, my marketing division is trying their best to get the word out. I've gone and met with a lot of physicians personally in the area, and to introduce myself and to give them my business card and contact information. So I would expect that if you mention my name to your doctor, or the fact that there's a new GI doctor at Conneaut or Geneva that I'd like to see, then they'll know who I am and be able to get a hold of me.
How about, I imagine that is something different, maybe before your time, as far as being a physician, is the marketing thing. Because I don't like when you're going down the road and you see your doctor's picture on a billboard. I mean, I've seen that.
Yeah, I think that things are changing as the times are changing. People want information fast. They want to use the internet, and I'm available. You can check on the University Hospital's website. You can see some more information about me there as well. And my contact information is on the website as well. So
they can just go there and make an appointment, or they'll get back to you?
Yes, absolutely.
Okay, excellent.
All right.
Periyalwar.
Close enough.
Periyalwar. Yeah. All right, and you're you're GI gastroenterology, and you're also an assistant professor of medicine. How did that come about?
I've always been interested in teaching and research. I've pursued a lot of research throughout my medical career, and I think that's important to me because it helps you stay relevant.
Oh, absolutely.
And so I continue to pursue that, and that's the reason I'm taking the case appointment.
So we have a call coming in. I don't know if it's for this or what. Let's find out. Hello, you're on the air.
Good morning. I'd like to ask the doctor if he is familiar with the LINX procedure that Dr. Katan does with UH-Giaga. I'm considering having that procedure done, and I'm a little bit hesitant and nervous about having something like that done. And I want to know if he knows any patients that have had that done.
I actually have had a few patients in my fellowship who've had the procedure done, and I know I've been in touch with Dr. Kaitan closely because I think we'll be sharing a lot of patients together. If you are nervous, I'm happy to see you in clinic, and we can discuss your options before she has to go see her. But it is a procedure which is for reflux, but I would recommend we use all of the other measures first before we get to that point.
Okay, very good.
Thank you.
Thank you.
So what kind of procedure is that?
It's basically you take a coil and you put it around the distal end of the food pipe to prevent acid reflux from.
Oh, okay.
It's a ring, basically a ring with the beads on the end. So there are certain measures which we take a surgical approach to, which means you go in there and you repair certain things. When patients have long-term reflux and your medications aren't working, maybe there's an anatomical issue at the esophagus. Those are all possible situations where you do it. I am in touch with Dr. Kaitan, and I'm meeting with her to just kind of discuss some of our overlap, and I will be referring patients to her. So it's not something which is I would never recommend, but it's something that you have to get to that point and be ready for that, and the risks that come with that.
Right. So it's good to have a discussion about that.
It is. Benefits and risks. If the benefits outweigh the risks, then you go for it.
Definitely.
So, but each person is different, so I can't give a generic answer.
What about ulcers?
Yeah. Well, funnily enough, I saw a patient the other day. They came in with abdominal pain and and more reflux than anything else, more heartburn. And I did an endoscopy just on Monday, and they had a couple of ulcers there. Yeah. So you don't know, you never know when to expect it, and there's certain infections which cause it, which is called Helicobacter pylori, which is a common infection, and that causes ulcers. Also, what a lot of patients don't know is certain medications like ibuprofen, Aleve, Motrin, they can cause ulcers, and people take these, they pop them for headaches and for pain, and they don't realize that they can actually result in ulcers. They say, well, I had a lot of headaches last week, but now I'm having stomach pain, and the only way we know is by taking a look. And I give you, after obviously we find it, we give medications to treat it and make sure it doesn't happen again.
Right. They used to say milk was good for that.
I don't think there's no proven.
I didn't think so.
No.
I'm not a milk fan, but that's all right. All right, well, thank you for stopping in. It's been interesting. It's nice to have a new service that people don't have to drive 60 miles from.
Right, absolutely.
Now we just need to get that Apple store here too.
Exactly.
All right. Thank you very much. We'll be back.